A very good day, good afternoon, good morning to all the attendees for this afternoon session. My name is Kogi Naidu, and I'm really pleased to present to you the new therapeutic choices that are now available for people living with HIV. My presentation will cover the approval pipeline for many of these agents, as well as the scientific evidence that supports the use of long-acting therapeutic choices that are becoming available. I will also discuss the current and future implications of long-acting therapy. We all know the current HIV therapeutic choices and the classes of drugs that are available to us and have been available for more than a decade. Entry inhibitors, NRTIs and NRTIs, as well as NRTTIs, the integrase strand transfer inhibitors and protease inhibitors have been well established in HIV care. Now, of course, we have several novel therapeutic choices in development. You can see color-coded in red those that have already garnered regulatory approval. In blue, undergoing phase 1 studies, in purple, phase 2 studies, and so on. You could see that among the entry inhibitors, the fostemsivir is a new agent that you're going to hear a lot about. We've been familiar with the Merck drugs, islatravir, and the new NNRTIs. Cabotegravir is also being investigated for both HIV treatment and prevention, a second-generation integrase strand transfer inhibitor. Monoclonal antibodies are now available for the treatment of HIV. Previously restricted to studies looking at HIV prevention, it is now becoming a therapeutic choice. And of course, several other products, the REV and maturation inhibitors, in early clinical development. Between 2020 and 2029, the iberlusimab, the broadly neutralizing antibody, has been approved for use for treatment of HIV infection. Cabotegravir rilpivirine, a combination of an INSTI and an NNRTI long-acting injectable, has also been approved, as is lenacapavir, a new first-in-class capsid inhibitor for the treatment of multi-drug resistant HIV. The future of HIV treatment will embrace long-acting injectables. Our current recommended first-line regimen are daily oral regimen. This we know already from our own clinical experience is burdensome to patients and therefore has impacted adherence and increases risk of treatment failure. Recent HIV research has really focused on treatment simplification. And the treatment simplification is really around improving adherence, improving side effect profiles, and therefore improving the quality of life among people living with HIV. This simplified treatment is as a result of drugs having a long half-life and therefore requiring less frequent administration. The long half-life also enables sustained viral suppression. These are new agents and new classes, and therefore overcomes pre-existing multi-class antiretroviral treatment resistance, especially those with multi-drug resistant HIV. And these agents now offer additional treatment options for people living with HIV. The cabotegravir and rilpivirine long-acting injectables were assessed in the ATLAS and FLAIR trials. These studies were published in the New England Journal of Medicine, differing by ART experience versus ART naive. Here, participants were randomized to receive either their current antiretroviral therapy or an oral cabotegravir in a lead-in phase of 4 weeks oral cabotegravir and rilpivirine in a lead-in phase of 4 weeks, followed by long-acting injectables administered monthly to patients. Outcomes were assessed at week 48. ATLAS looked specifically at ART-experienced patients, whereas the FLAIR study looked at patients that were ART-naive. It's important for generalizability, as the ART-experienced patients were receiving a whole range of products from different classes prior to being administered these long-acting agents. Those that were ART-naive had any pre-ART, pre-treatment resistance associated mutations excluded prior to trial participation. At 48 weeks, the study showed excellent HIV suppression rates in patients receiving either the monthly long-acting injectables or those receiving the standard oral therapy. Suppression rates exceeding 93% were observed in both arms, and concluding that the long-acting agents was non-inferior to the oral regimen. Only 2% of patients across both arms experienced virologic failure at greater than 50 copies per mole. Injection site reactions were fairly common. These were mainly mild to moderate, and only 6 out of about 600 patients required drug discontinuation as a result of this injection site reaction. Patients from the ATLAS study that we've just discussed were assessed for an additional 48 weeks and re-randomized to enable evaluation of whether 4 weekly versus 8 weekly long-acting injectable created a different virologic outcome. So basically they assessed whether a 4 weekly or 8 weekly injection was non-inferior for antiviral efficacy. What the study demonstrated was that HIV suppression rates were similar in patients that received either monthly or 2 monthly long-acting cabotegravir and rilpivirine. You can see in the purple bar where patients received 8 weekly injections, and in the green bar where patients received 4 weekly injections, virologic suppression rates were extremely similar. And those that had a virologic non-response or viral failure of greater than 50 copies per mole was also very similar at 1.7 and 1% respectively. Lenacapavir is a first-in-class capsid inhibitor, and it's been evaluated in 2 studies, and these studies are still ongoing, but I thought it was important to sensitize you to this drug and its development. Patients with HIV viral load of above 400 that were known to be resistant to more than 2 agents from our main ARV classes and had less than 2 active agents as part of their regimen were randomized to receive first a monotherapy of lenacapavir for 14 days, followed on by a maintenance phase of either subcutaneous or oral lenacapavir that was administered for 52 weeks. What you can see is the potent antiviral activity in the first 14 days amongst those that received the functional monotherapy of lenacapavir alone, where 88% of participants achieved their primary endpoint of a greater than 0.5 log drop in their viral load, compared to 17% in the placebo arms, showing the potent antiviral activity of lenacapavir. So despite patients being heavily treatment experienced with multi-drug resistance, overall, lenacapavir demonstrated a 1.9 log decline by 14 days of HIV viral load. And when used together with the optimized background ART regimen, created virologic suppression rates of about 81% by week 26. The drug was extremely well tolerated with no adverse events leading to drug discontinuation. And so lenacapavir, therefore, could be an important choice for highly treatment experienced patients living with HIV, including those with multi-drug resistant HIV. The Calibrate study also assessed in a phase 2 trial in treatment-naive patients the safety and efficacy of lenacapavir-containing regimen. Here, participants were randomized to firstly an induction phase followed by a maintenance phase, and in the induction phase received either oral or subcutaneous lenacapavir administered every 6 months. As you can see by the graph, within 4 weeks, more than 80% of participants achieved viral loads less than 50 copies per mole. And this was sustained over 28 weeks. So again, this lenacapavir was extremely well tolerated and safe. The study is ongoing. Long-acting injectables offer many benefits of simplified ART, less frequent dosing, thereby creating a reduced burden to both patients and our pharmacy services. Potential rescue treatment for those that have multi-class resistance to HIV. There's no known overlapping resistance profile for many of the drugs, the existing drugs, and therefore it can overcome pre-existing resistance. Apart from rilpivirine, which is an NNRTI, most of the other agents have no overlapping resistance profile. And it will offer us more choices for patients and providers. The problem, however, is we're not sure yet about the costs and cost effectiveness. We're not sure about the resource use for implementing long-acting injectables in settings that are resource constrained. Is it going to be affordable for Africa? And that's a question that remains unanswered. Some of these agents require a cold chain. And so for those deep rural health facilities, it may be problematic offering long-acting injectables requiring cold chain for maintaining drug integrity. For drugs to achieve registration, you need to have enough clinical trial data from diverse populations. So currently, most of these long-acting injectable agents have been tested in settings outside of Africa. In fact, more than 75% of populations participating in long-acting injectable studies are from the US or the UK. Underrepresented resource-poor endemic settings in trials will impede scale-up in Africa. We have very little data from women, as less than 30% of study populations thus far for the data that I've presented have come from women. Almost no data on safety and efficacy in pregnancy and among children and adolescents. As you saw from my slides, many of the trials included patients that were ART experienced but virologically suppressed. So they already, we know, have optimal adherence. And adherence to a schedule for administration of drugs is very important, whether it be oral or injectable. And the extent to which a long-acting injectable is forgiving versus emergence of resistance is still poorly understood. Therefore, there will always be the threat of acquired resistance to the new agents. Data that was released recently from France has shown that already amongst pre-treatment patients, resistance to rilpivirine is at around 7%. Introducing injectables to millions of patients in resource-poor settings may create long queues, congestion in health facilities, and concerns around needle safety. And these implementation challenges require more research in order for us to understand how to best introduce long-acting injectables in our setting. My presentation will not be complete without describing a few other studies that have an impact on therapeutic options for people living with HIV. The WHO guidelines recommend 3TC and FTC in both first and second line ART. Dolutegravir is reserved for second line ART among patients not exposed to dolutegravir in first line. AZT is used in second line largely due to the pill burden required, the toxicity, and because of the toxicity, the need for frequent lab monitoring and the associated cost. The study NADIA, nucleosides and Duranavir and dolutegravir in Africa was a randomized study conducted in Uganda, Kenya, and Zimbabwe, where 465 participants were randomized to receive either dolutegravir and 2 NRTIs compared to Duranavir and 2 NRTIs. The NRTIs were either tenofovir and 3TC or AZT and 3TC. The study showed that the dolutegravir regimen was non-inferior to the Duranavir regimen, supporting the use of dolutegravir in second-line ART, which is excellent, so it's in support of the current WHO guidelines. The data also showed that tenofovir use in second line was non-inferior to zidovudine, despite a significant proportion of patients having pre-existing resistance to tenofovir and 3TC. There were high levels of viral suppression at 48 weeks, with more than 90% of patients having a viral load of less than 400 copies per mole. So despite extensive NRTI resistance and very little predicted NRTI activity, maintenance of dolutegravir in second line was being supported, and this is against the current WHO guidelines, and so would need to be reviewed. This evidence would now need to be reviewed, and the recommendation from the WHO revised. There was a 6% rebound in viral load to more than 1,000 amongst patients in the dolutegravir group, and 4 of those patients had a major resistance mutation to dolutegravir. And so this again providing this new therapeutic option using old or existing drugs helps support a public health approach for ART delivery in Africa. Islatravir is a oral long-acting ART and has been evaluated with another oral long-acting ART, doravirine. Islatravir is an NRTTI, long half-life of 120 hours, whereas doravirine is an NNRTI. The Merck-sponsored phase 2 studies is a dose-ranging trial of oral islatravir doravirine compared to doravirine, 3TC, and tenofovir, so it's dual therapy compared to triple therapy in treatment-naive participants. The dose of 0.75 milligrams is being selected for advancement into phase 3 evaluation after the finding that the dual therapy of islatravir and doravirine maintained viral suppression at week 48 with good safety outcomes. Ibalizumab is the first monoclonal antibody for the treatment of HIV infection. It's an entry inhibitor that is a long-acting agent and prevents the entry of HIV into the CD4 count. It actually works not at the point of entry, but at the point of post-attachment changes that occur within the HIV envelope. This monoclonal antibody provides an additional option to achieve and maintain HIV viral suppression in heavily treatment-experienced patients. It's not used alone, but in combination with other antiretroviral agents. It's given as a loading dose followed by an infusion over every 2 weeks. The preliminary data thus far has shown that by week 25, there is a 1.6 log drop in viral load, with about 43% of patients achieving a viral load of less than 50. A poster presented in CROI in 2021 demonstrated that the outcomes between week 25 and 96 were very similar to those observed in week 25. And as you saw from my initial slides, this product is being advanced and approved for use in HIV treatment. So to summarize my presentation, we've heard that the innovations in HIV therapeutics have now several new additional drug classes as well as new compounds that carry an enormous potential to simplify and enhance chronic HIV care. They offer hope, especially to heavily treatment-experienced patients and those that have multi-class HIV drug resistance. The impact of these long-acting injectables and new therapeutics is still poorly understood in treatment-naive patients and in African populations. We need further research to understand who would likely benefit the most from these products, where to locate services for long-acting injectables, how to appropriately find and triage eligible patients for long-acting injectables, and how to deliver services for long-acting therapies within busy health facilities. Further empiric data guiding implementation, such as the cost effectiveness, how to access these agents, what are the suitable patient and provider criteria, as well as drug interaction data is required. We don't yet know about the safety and tolerability of many of these agents when co-treated with rifamycin, for example, and we know TB is a big problem in Africa. We are now entering a realm of a new era in HIV therapy. The shifting paradigm in treatment requires both patient and provider education and advocacy. Thank you very much to J&J Global Public Health for inviting me onto this forum, and thank you very much for your attention. Over to you for your questions. Thank you.